Well, welcome everybody. It's great to be chatting to you again, live from Barcelona. And Brett and Martin and myself are attending the ESCMID Global Conference 2024.
Now, for those of you who don't know what ESCMID is, Brett's got to explain it.
Well, ESCMID is what I describe as the largest infectious disease microbiology IPC conference in the world. I think there was about 20,000 delegates for this conference. And I guess to give you a scale of it, there are about 20 concurrent sessions going at any one time, with rooms up to holding probably 2,000 or 3,000 in some of the rooms, as well as a poster room, which is turns over every day about 500 posters, arena sessions, flash oral presentations, and countless other things.
And an enormous exhibition of machines that go beep,
water fountains,
or drugs that you're going to run out of quite shortly.
But no infection control companies whatsoever. That's
no
good.
infection prevention.
Well, the laugh for me is, if you had good prevention, you wouldn't need any of the rest of the exhibition.
That's why they don't want it there.
But there's no hand hygiene companies. No. There's no nothing for an infection prevention.
You know, when you're going to a conference and it's big, when you turn up to the nearest train station. Actually, there's 2 train stations that you can get off at.
As we found out, one gives you a lot more steps.
Yeah, and the train station is covered in advertising material. For the conference, that's still probably a kilometre walk away. It's absolutely enormous. It's actually quite overwhelming if you don't have an app. Hence our joke the other day about the app not working. If you actually don't have an app, because if you printed the program, you would chop down 25 trees. And the app is that's why you have to have the app, because it's just you don't know what's going on at any given time. So anyway, that's ESCMID. It rotates around Europe every year. Oh, not all of Europe, because there's no venues that can hold as many people.
Yeah.
Well, that's the issue. It tends to rotate around the same sort of countries.
So if you haven't been to ESCMID, I would definitely put it on a to-do list if you're interested in an international conference. It's probably the one I look forward to the most.
And actually, just to stress, as a nurse, it's cheap.
Yeah.
For a nurse, it was something like €70.
Yeah.
So that's about 62 quid, something like that, which is, compared with every other infection prevention conference around the world, it's an absolute bargain. So, you may pay a bit to get here, although not if you go with Ryanair.
In Australia.
Yes. And you're going to pay for your hotel accommodation, but the actual conference itself is extremely reasonable. And it's fair to say there's been a lot more IPC this year than I've ever noticed.
And also they throw in a lot of things, like there's free transport on all public transport chains.
As we found out after we bought the 4-day tickets.
But yes, there has been more infection control this year than any other time I've ever been to ESCMID.
I particularly like the flavours that we get. They're all from all the different countries.
The wine or the beer?
Well, the wine, the wine, not the beer so much, but the flavours of the different countries of people presenting. I find it really... it's great, because you sort of realise that what you're doing, you're not alone. There's other people doing similar things in different countries.
And in fact,
sometimes you've done things before other people have done them. So I like the flavours that we see.
I mean, I love the comment on this in the session, pragmatic approaches to infection control. There was a speaker from Italy who said, of course, in Italy, being Italian, we're not pragmatic.
Yes. And nobody laughed except us.
The other thing that amazes me, the speakers get up and present in English.
Yes.
And for a vast majority, that's their second language.
I mean, you're going to struggle with that tomorrow morning.
I'm going to struggle when I present tomorrow. I can't speak good English. And they do that, and then they get questions, and hard questions.
Yes. Very technical questions.
And very technical questions that doesn't always translate. But I'm just amazed how people get up and do
I'm
that.
humbled by people's ability to work at that level in not their first language.
So today, what did you see, Martin?
Well, we kicked off with the cleaning the occupied bed space session in the environment session, which was nice. Pierre Pinex from the Clean Hospitals Programme chaired it. Kicked off with Stephanie Dancer doing what Stephanie normally does, pretty comprehensive review of the literature and a few generalisations that aren't entirely supported by the literature, but as always, very entertaining and quite a bit of discussion afterwards.
And I guess that's the beauty of some of the talks, it's good to stimulate some conversation, even if it's just with the person sitting next to you. You might go, well, I don't necessarily agree with that, and why, and vice versa. You get your ideas challenged. And one of the things that challenged me in that session was this concept of probiotic use.
Yeah, that was interesting. A very enthusiastic presenter as well. Prof Cassini. Well, maybe stick a couple of links to a couple of her papers that are attached to this podcast.
But, I never really thought about the use of probiotics as a cleaning agent. And there's a lot of work being done in that space.
Yeah. I mean, I'd heard of it years ago, but the volume of work she presented today, you start to think, okay, and it's
open
got
your
a lot
eyes
of
to that.
potential.
Yeah, I think, and in fact, I heard a lot of people talk afterwards about that. It's like, well, it may not be there yet, but there's a lot of potential there, and it made you really think this could be the way that things need to move in the future. It may not be as well, but it
may not be.
It could well be.
I mean, it's fair to say the publications haven't been what I would call the mainstream journals, just occasionally.
I think there's been a lot of foundational work that has to go on.
Absolutely.
So that you're not doing harm, and so I think that's where a lot of the work's been concentrated on to date. So that was a fascinating.
Yeah, that was really interesting.
Yeah.
And then
I'm glad we got Martin to remember the names, because I'm not good at remembering anyone's names anyway.
I'm sitting here thinking, trying to remember what I did see today. I guess the one that stands out for me more clearly is Dev Anderson's talk about preventable surgical site infections, and he defined preventable surgical site infections as those
every surgical site.
well, in particular, those infections, surgical site infections that occurred where an element of a bundle wasn't done. So if there was 8 elements of a bundle and one of the elements wasn't done, so not 100% compliance, then that was considered, and the patient developed a surgical site infection, then that was considered to be a preventable surgical site infection.
Oh, I do quite like that.
I really like that neat.
That's interesting.
But he did admit, though, that he doesn't know. So they only looked at those patients who developed a surgical site infection. He didn't look at the patients who didn't develop a surgical site infection and see what the compliance rate was with their bundles in that situation. But that's obviously something you can do later on down the track.
Yeah, someone asked that question, didn't they?
I do like that definition of a preventable surgical site infection.
For those who DICON is the sort of infection control network that Duke set up. It's a great thing. But again, going sort of broadly, like this is when you go to a presentation at ESCMID as a speaker, you get drilled, and people will find the perfect question to ask, and that was a great example of that, presenting some fantastic work, and then someone asked that question about have you ever looked at people who haven't got surgical site infections? So,
because I get the bundle compliance, because years ago I got involved in a piece of work with Judith Tanner and David Leeper, and we put in place a 9-point bundle, and the infection rate didn't really change. In fact, in the deep infections it was similar, but in the superficials it actually went up, and it was 1 in 5 got the bundle. So everyone now, 80% got suboptimal care as far as I'm concerned. So I really like the idea that it's a preventable infection if you've missed something out. So it's like guilty till proven innocent almost.
Because the bundle is made up of elements that have got great evidence behind them.
Dev Anderson? Not Dev Anderson, we just talked about Dev Anderson.
No, you're thinking
David Weber.
Now. Oh, David Weber.
No.
David Weber.
No, Curtis Donsky. See, there we go. Curtis Donsky today.
You Australians, you can't remember anyone's name.
Gosh, I tell you.
Mind you were called Bruce.
Yes, I was called
Bruce. Yes, Bruce.
Curtis Donsky talked about the use of UVC in particular. He presented a really balanced view of the pros and cons of ultraviolet light, and in fact a little bit before that, more other automated systems as well, non-touch systems. And I really like how he just very, very balanced on the pros and cons of them all and where the evidence sat.
So this is talking about non-touch disinfection of surfaces and hospital rooms. Yes,
sorry. And then moved on to UVC and was talking about the potential of UVC. This is sort of far UVC, and it doesn't have the sort of health and safety issues. It doesn't have the cost issues. It can be used, situations that were quite interesting. So one of them was thinking, well, could we use that far UVC around the sink splash zone?
Yeah. I really like that.
And that's a cracking example of some innovation there.
Yeah, because, I've seen paper after paper after paper saying we've found all these horrible things down the drain. How's it coming out? Well, but, so if you can start decontaminating the area automatically around so that if something does get a splash, it gets sorted out by the far UV. And I quite like the fact that if somebody approaches the sink, the lamp switches off.
Yes.
So that was quite nice. But although it does mean in some hospitals it'll never turn off.
Yeah, that's true. Yes. And look, I think he also went through the health and safety are very different to UVA and UVB. So that was good talk too.
I do wonder though if it's effective if there's wet, if it's still wet surfaces around the sink.
Yeah.
Or does the surfaces
do we
need
know
to be
if that
dry?
Penetrates water.
Yeah. I don't know.
No.
That would be.
I mean, light does penetrate water, but it changes, doesn't it? Because a swimming pool with white tiles looks blue when you've got it full of water. So I don't know what that does to it. And he didn't know much about what continuous UV would do to material compatibility.
Yeah.
Because I know if I leave my garden plastic chairs out all summer for a few years, one year they're just going to drop apart because the UVs.
And the other robot-y type UVCs that go around, I think there was some commentary about them potentially causing some discoloration.
At least yellowing, but possibly other damage as well. So. Yeah. But I thought there was a lot of interest in that, and as you say, a nicely balanced presentation.
We went to a talk about wastewater.
Yeah, it was a flash session, wasn't it? Lots of short posters. Very good.
About 6 or 7 sessions in maybe half an hour.
Quite a few from Ireland, actually.
There were,
Seems to be a lot of interest in wastewater in Ireland.
Why is that?
And it wasn't quite how I thought some of those things would pan out, because I was thinking that perhaps that theme of that session was going to allude to, could we look at antimicrobial resistance in wastewater, genes and various other things that might give us data longitudinally or an early warning mechanism to be able to go, okay, if we're looking at hospital wastewater, we might see something there, like we saw with COVID-19, looking at water for COVID-19. And could we have any value of that in IPC as an early trigger to identify things that we're not picking up through screening environment and screening of patients, because we're not doing it, or we don't do it for everybody, and we don't necessarily do it that well for everything. So they didn't go down that route, but it was kind of alluded to that.
Yeah.
But there were some interesting presentations, and I think we're going to try and get at least one, hopefully, one of those presenters on.
Yeah, there was a group from Ireland who was suggesting an outbreak was related to shower drains. But unfortunately, it was more the laboratory folk who were presenting, so they couldn't tell you whether the people who picked it up actually had a shower. Yeah, which I would, that's what you need to talk.
Look, and then I think we've chatted. So this is a great example of like the amazing things that genomics can add. But you still need to have the epidemiology
stuff
and the IPC, because to me that would have been better led, that presentation, from someone in IPC, not in the lab, because they could have used the expertise of the lab to say, this is what the lab's told us, this is what the EPI's told us. Because there was, I don't understand, for example, they use hydrogen peroxide vapor.
Yeah, I'm not sure.
And there was something else they used. I don't really understand why or how. Anyway, so those are the kind of things I think that would be better answered by someone there. So anyway, it'd be good to have that conversation with that crowd, and we'll try and get them on Infection Control Matters in a future podcast.
Yeah, but I did learn it was illegal to pour chlorine down the drain in the Netherlands, wasn't it?
Yes, it was the Netherlands. Yes,
Netherlands.
Yeah.
And
then, Denmark.
Yeah. Okay. And the speaker didn't realise either until she's done it.
Yeah. That killed that experiment.
Well, speaking of chlorine, Martin, I think you've got a nice little paper out in the Journal of Hospital Infection talking about the challenges with using chlorine.
Yeah, I mean it's an opinion piece, and a few of us got together because we look at the National Infection Prevention and Control Manual in England, which is based on the Scottish one, which says cleaning with detergent and chlorine is fine. And we don't think it is. We think that's a bit dated because there are different agents available now. I know from a little piece of work that Mark Garvey's been doing in Birmingham, he actually went around and sampled the chlorine that had been made up for use, ready for use on the wards, and it was all well under 500 ppm average, and it's supposed to be 1,000. Some are as low as 40 ppm, so this is homeopathy.
Yeah, you drank that.
So, well, you probably. I mean, it's less than milk.
Donald Trump does, doesn't it?
And to me, it just doesn't fit with the human factors approach either.
Yeah. Now, are we going to talk about this now, or should we leave that for another? I wonder, because it was a really good paper, and I wonder whether we have
Stephanie Dunser didn't think so, but that's another. I can't tell you what she said, obviously, because that would involve
swearing
words.
I think
the beeper.
I think we'll leave that, because I think that paper is a really complex paper, summarised nicely into just a couple of pages.
We'll have another chat.
Yeah, so look out for that one.
Okay. Phil, any more takeaways from today?
Barcelona's a lovely spot.
Okay, we're starting to waffle now. The only takeaway I've had today was a terrible burger at the conference. So
that's one thing I haven't done well.
No, we didn't communicate that.
And from what I know about wayfinding, that could be improved upon as well.
Yeah.
Yes.
Okay.
Well, the other thing I would say is in our cleaning session this morning, there was a paper presented that was a randomised cluster crossover trial, a very, very neat design. Actually, I really liked it, and they were comparing the soap versus
alcohol, wasn't it?
Versus a probiotic, and there were, I think, 18 non-ICU wards, 3 different clusters, 3 different groups with a washout period, and they were comparing the incidence of healthcare associated infections. Now, I think that was a very nifty design, and kudos to them to try and pull that off, because that's the kind of studies that we need. Now, I'm not necessarily convinced about what I believe was the outcome of that study.
Yeah, they said they were all equal.
Yeah, there's no difference in using quats or against the soap and the probiotic.
I mean, the rates were slightly down, but it wasn't significant. So
no, there were less cases. There were less cases in the disinfectant arm of overall healthcare associated infections.
Yeah.
And less cases specifically of MRSA infections, but not statistically significant. And so I don't necessarily agree with the conclusion that the authors came up with that they're the same, because for several reasons. First of all, it's not set up as a non-inferiority study. So if you're setting something up as a non-inferiority study, you have to determine what is the level of acceptance you're willing to be harmful or less effective or more effective, and that's not how that study was set up. So I think the conclusions are misleading personally to say that. It's like saying like gloves and gowns, right? If you're going to get rid of gloves and gowns for contact precautions, you're not comparing the benefit of gloves versus gowns on an incident rate. You're trying to say, is one going to cause more harm or benefit if you take it away, and therefore you're looking for a margin of error. And that's not how that study was set up. The other thing I would say is that the study was powered to a point prevalence of 3.6%.
Yeah, which was the national
rate. Thing. Yeah, which is fair enough, right? That's a good. Well, we've done that in our own studies. Yeah. But point prevalence is different to incidence, and obviously a point prevalence is going to be a heck of a lot higher than incidence. So if you look at studies like Phil, the point prevalence in Australia was what, about 9%?
Almost 10%.
10%?
Yep.
The incidence of healthcare-associated infections will be probably less than 1%. Mm-hmm. 1%.
Dancing around there.
Dancing around 1%. Yeah. So that gives you an example. So 3.6% was their point prevalence sample size calculations. Their incidence of infection is how they actually analyse their data. And the incidence was around the 1.7% mark. 1.7 cases per 1,000 bed days. Yeah. So that's a very, very low rate. And for me, that study unfortunately is not powered to answer the questions that was done.
And the other thing is, they were retrospectively picking up infections,
which is what pragmatically often.
Pragmatic because they didn't have enough people. Yeah. But the problem is, at that point, they're not picking up. They only find out how low their infection rate is quite a way into the study. Whereas if you'd have been doing it when it's finished, actually. Whereas if you've been doing that from the get-go, you'd know pretty quickly. Actually, our incidence is really low. Therefore, we've got to include more patients in it. But they weren't able to do that until after they'd done the study, In which case, you're stuck with the number of patients you've got in.
That's right. Look, and that's why, again, I don't want to be critical. Kudos to the authors for trying to pull it off. This is what happens in real life, and this is why these things are difficult. But I guess what I'm getting at here is you look at the headline, you go, oh, there's no difference between quats, probiotics, and soap. And I think that's the devil's in the detail, and that's not how I would interpret that paper. I'd also say that if you actually extrapolate out, for example, the MRSA component, there was one case in the quats arm, and there was 6 cases in the control reference group arm. Now, if you assume the same rate, but you increase the number of participants, so you double the number of participants to get to what I think is probably more closer to the accurate sample size required, then you're actually very close to reaching borderline clinical significance of quats reducing MRSA infections. Yeah. So there lies the devil in the detail about getting these things right, so you don't make erroneous conclusions.
Another thing I did pick up with that is, actually, the probiotic was no worse either.
No, that was the other positive of that study. Actually,
yes. That adds a bit to the. We need to look at probiotics in a little bit more depth.
And obviously, they didn't cause too much harm. Again, it's not powered for non-inferiority, but there wasn't an increase, and so again, that's why that study is really useful. And I don't want to cast too much negativity on that study. I'm just saying that there were things I wouldn't jump to big conclusions about.
But it's a good design. If you just tweak the design a bit more, then you have the basis for another study.
Yeah, I reckon it's a study worth repeating, that type of design, and include more patients, and ideally, if there's some kind of way to collect data a bit prospectively, even better. But look, this is where we talk about the difference. Pragmatism has to be there with how we do stuff, and so you're not going to have a gold standard.
No.
So well done to the authors on pulling that off anyway.
Yeah, we'll put a link to that, of course, in the podcast description. Okay.
Right, we've got to head off because
somebody's got a big talk tomorrow.
Yes.
Yeah.
Maybe we'll talk about that one as well.
Yes.
Well, we could talk about that actually tomorrow. We're going to do that after this because anyway. There's also an important dinner to get to. So,
Okay.
All right. Thanks everyone.
Bye, ciao. Everyone.